So, birth plans. So, how many of you have made your birth plans now? They used to put them, in fact, you don't have the green book anymore. You used to have a green set of what they used to call the green notes. I don't think that's the thing anymore. Is it all on an app or something? All your medical information?
Mine's in a book. It's not a green book anymore, but it's really similar to the green book I had last time with
Okay. So normally there you get like a birth plan section.
Yeah, there was a little section I think, but it's not very big, so.
Yeah, but they don't want it to be very big. That's the one that they give to the maternity one. They don't want a big, birth plan. And have you got something on your app for that?
I've done it with the hypnobirthing and positive birth company. I've done one too.
Yeah, I thought you might have been able to do that as well. So this is just a recap for you then, revision. Okay, so put here, discuss with your partner and your midwife, if possible, what your ideal scenario would be. Keep it really simple. Remember, the midwife will have to read this on your arrival. So, if the maternity ward is quite busy and you've written 14 pages of, I would like pretty pink lights and some lavender aromatherapy, if they haven't got time to read that, so you need to keep it fairly, what do they want to know? So it says what are the deal breakers? What are the things you absolutely must have in place, all things being equal? So a birth plan is exactly that. It is a list of your wishes, not a contract. Labour can be unpredictable, so make allowances for all eventualities and be flexible. Make some brief notes on your thoughts on the following topics, and then transfer a brief summary of this onto your birth plan. So this is again just a little bit of ideas to get the brain working. So some of you are, Leah, how many weeks are you?
19.
Yeah, this is
I haven't even thought
half this then, yeah. No, we've got a few people who are nearly due, so I thought it was time to have a look at labour. But it's a good revision, good to have it back in the brain.
Thinking about, for sure.
Okay, so the first thing to think about is who's going to be present. So for most of you, that will be your partner. Not always. Sometimes partners are not helpful, so you might actually prefer to have a different family member be with you for your labour. I haven't had cases where they've left the husband at home or the partner at home, and a sister or a mother or even a cousin has actually been the birth partner. So bear that in mind. If your partner really doesn't feel that they're up for the task, there's no point taking them in, because you will end up looking after them. And I mean, you laugh, but it is really common. It is really common that the woman is nurturing the partner because the partner's not coping. You haven't got time for that. You haven't got mental or physical capacity for that. So if you really don't think they're going to be of value, politely suggest that they go down the pub instead. That's how it used to be in the olden days. And we kind of think of it as being a bit backward, don't we? Or dad was down the pub having a pint, But actually, women kind of just want female spaces when they're birthing in a lot of scenarios. So bear that in mind. You will need to put this on your plan for hospital security reasons. They need to know who is going to be attending you with your birth, particularly if there's more than one. So if you're having more than one person attending, it might be a bit tricky, especially in COVID times. You might only be allowed one, whereas previously husband might have been able to kind of flit in and out and run and get you things you needed, but there may have been like a sister or a cousin or a best friend who would have actually stayed the duration with you. So that would have been quite a common scenario before, because husbands are quite good. I keep saying husband, that's not really good, is it? Partners are quite good at running and fetching. They like something to do. And actually, the people who will prefer to sit and hold your hand will be the female people in your lives. So just bear that in mind. All things being equal gender-wise. What will any additional attendees' roles be? So again, thinking about who's coming and what will you want them to do. What is their role going to be? You know, is it forehead stroking? I did have one lady at one point who said that I think her husband stroked her hair throughout the whole labour, and that's all he did. And she said, I couldn't have done it without him. And she was absolutely serious. Just the fact that he was there and he stroked her hair all the way through, she said it was the best thing he could have done. And I don't think if he hadn't done that, I don't think I would have managed. So, you know, it's interesting to see what that role might be. It may not be as big or grand as they're expecting it to be, or you're expecting it to be. It can be something really simple like that. So you can put that down. Can you stroke my hair? They can do that. They can come. So again, the role of your birth partner. So again, thinking about who is going to be your actual birth partner and what level of involvement would they like to have. So there's quite a lot of things that are available. So things like massaging, they can do sacral massage, lower back massage, hair stroking, as we just said, cord cutting. Do they want to cut the cord? Would they like to be in the pool with you? So if you're having a water birth, then in some cases, providing the pool is big enough, then the partner can come into the pool with you, and that's not uncommon depending on the size of the pool. Do they want to catch the baby? Do they want to be the first person to hold the baby and help the baby out? Again, that, you know, all things being equal, is a possibility. So have a discussion with your birth partner, who's going to be there to support you. What do they want to do? What are they prepared to do? What can they do? And what do you want them to do, which is more important? And then thinking about what type of labour would you like. So let me just give you this. So there are lots of different ways of labouring, and you know, you choose the one that that you like the look of. But you know, again, all things being equal, you may have issues that arise which will change during the case of your labour, at the time of your labour. So do you want a home birth? Do you want a water birth? Do you want an active labour? So that's what we do here. So active labour is getting up, moving around, you know, wiggling your hips, doing some breath work, being an active partner in this labour process rather than just lying on your back and kind of being a passive partner to the labour process. So active labour is you getting involved, moving and breathing. Do you want to use a birthing ball? Do you want to use a birth stool? So a lot of the midwife units now, maternity units, have birthing stools or some kind of modern take on a birth stool, which helps you to squat. So that's what they're for. They're a supported squatting device. So again, we've gone right back to, you know, almost medieval times when women would have birthed on a birthing stool, and they were seen as primitive, and now we've gone all, you know, all around full circle to the point where, like, no, they weren't primitive, they're absolutely marvellous, and it's exactly the position a woman needs to be in to deliver a baby. So we've now come back around. So we've talked about induction as well. So, you know, discuss any preferences or fears around the issue of induction and state this on your plan. Would you prefer natural induction methods as far as possible? And there are a few natural induction methods. So reflexology or acupuncture is a good one. And aromatherapy oils. I think, you see, at the Samuel Johnson in the midwifery-led unit, they had a lot of people there that were trained in all of these modalities, and they did labour reflexology, which I'm trained in as well, and aromatherapy. And they would give you a bottle if you were kind of overdue, you know, or getting close to your due date. They'd give you a bottle of pre-blended aromatherapy oils. They say, put this in the bath and, you know, smell it and things. And so they used to get a lot of this additional care, which, you know, doesn't really come within the remit of the NHS. So I don't know if that's the case, because those midwives work at Burton now. They've been redeployed. So I don't know if that's an option at Burton. So maybe ask. You know, it was something that they did all the time at Samuel Johnson. Or you could just go and see an aromatherapist. And then we talked before about all the other different induction methods, you know, so having a sweep, that's always a good one to start with. Then maybe another pessary, and with prostaglandins in, so that's the second stage, and then the third stage is the full-on oxytocin drip, or it's not proper oxytocin, it's the what's it called? Syntromet. Oh, blimey. What now?
Begins with a sin.
It's not syntometrin. See, 2 years of not doing this, I've completely forgotten all the long words. So that's the artificial oxytocin, and that's the full-on range. And then, as we mentioned before, other induction methods that are tried and tested are, like date night, curry and sex. So they are quite effective. It's not the nicest date you'll ever have, but gets the baby out. And then thinking about what pain relief you may wish to be given, and if and when you need it. So there's like a range of different pain relief mechanisms available. So from the really kind of low-key stuff like paracetamol, maybe a TENS machine, some massaging. Water is a very good pain relieving mechanism, which is why birthing pools are so useful and so well loved for labour, because they do seem to take the edge off it. But if there's no birthing pool, then I know at Samuel Johnson they used to have lots of rooms with like baths and showers, so having a bath can be really useful. It's not easy to get in and out of when you're pregnant, but having a shower and just running the jet on your lower back if you're labouring for some time at home. So just having water can be quite useful. And then pethidine, which again is kind of like the medium range. And then Gassionaire, which is a kind of a low range of Gassionaire, pethidine, and then epidural, which is kind of the, epidural is kind of the top range. And even they've got better, because previously an epidural would just knock you out from the waist down, so you'd have to lie on your back, and then you have all the problems associated with that, like baby may get stuck in the pelvis because you're not in a good position, you don't know when to push, so all of these things kind of ramp up. But I think they've been developing what they call mobile epidurals now, where you can actually be a bit more mobile. If you do want an epidural, check if that's an option. Can you have a mobile epidural? Will you be able to move around? Because you want an active birth, you don't want to be lying on your back. So if you have an epidural, will you be able to move around? And then monitoring. So this is something that's changed as well over the years that I've been doing this work, because women were monitored as a state of a sort of general admittance. All women were monitored. And now it's changed where they're not doing that anymore. As you are likely to want to be mobile during your labour, it may be useful to state that you would prefer intermittent rather than constant monitoring, if that is appropriate for the circumstances at the time. So again, the monitoring equipment has changed as well. So it used to be you had to lie down on your back. There's a theme here, isn't there? Lie down on your back. And not move, because if you move, the trace wouldn't be as effective. But now they've got mobile monitoring ones where you can actually kind of bounce on your ball and move around, so you can do that. And this was told to me by the midwives at Samuel Johnson, that a lot of the monitoring that used to be done at Burton, this is just on every woman that walks in, was so that they could just know which room to send the delivery midwives into. They'd see them, contractions getting closer and closer together. They go, all right, room 5 might be ready to push, and then they would go, right, everyone to room 5. And it wasn't at all to do with anything other than staff management. Where do we put the staff? But it makes women very, very uncomfortable. It makes labour very long, and there's that feeling of being out of control again, because you're not active, you're not moving. So you need to discuss monitoring towards the end. When you have your next, if you're coming towards your due date, talk about monitoring. There are certain cases where you do need to be monitored. If you have an underlying health condition, if you have a high risk pregnancy, there is every chance that you will need to be monitored throughout, but you'll already know that. You'll have already been told that. And I think sometimes when you're induced, they need to monitor the baby all the time, because it's very rough for the baby. It's not the gentle, because the normal sort of trajectory of labour is it starts slowly, builds up a little bit, builds up a little bit, builds, so you have time to get used to it, but so does your baby. And when you have an induction, it's 100%, 0 to 100 immediately. So it's a shock for you, but it's also a shock for your baby, and so they have to monitor your baby to make sure they're okay. Again, when you're induced, it's slightly more difficult to move around because you're now attached to a monitor and a drip. But if it's all possible, try and be upright or over your ball. It's very important because when you've had an induction, it is very, very uncomfortable. And so if you can make yourself as comfortable as you can, so you need to have that conversation. If you're going to be induced, what are my options for having a mobile labour, an active labour? The actual delivery of your baby. So again, discuss any preferences for how you want to deliver your baby. So this is the part where you push and out comes your baby. Do you want to deliver your baby in the water if you're in a pool? Do you want to deliver on all fours? Do you want to have your partner, I've written dad there again, I need to be very more gender neutral, don't I? Partner to catch or deliver or catch the baby. I've put dad to deliver, that'd be funny, wouldn't it? I need to change that completely. Yeah, they're not going to be delivering anything, oh pizza. Okay, third stage. We talked about this a little while ago. We had a conversation about third stage. And I might spend some time going into this in a bit more detail if it is of interest. You've got two options with third stage delivery, either managed, which means it's done with drugs. They give you some artificial oxytocin, and then the midwife does a lot of massaging and tugs on the placenta lightly, so it's a lot quicker, it's a quicker delivery. That's usually the case of things like twin deliveries, if there's a high bleed, if the mum's high risk, and there's a catalogue of reasons why sometimes a managed delivery is more preferable. But if you've had a straightforward labour and your baby's fine, then in a natural placenta delivery should be quite normal. And again, it used to be the case. I mean, it's surprising now looking at the way things are in terms of everything needs to be consented now. It's really interesting to look 30, 40, 50 years ago. Things were done automatically, like women were always cut, episiotomy, regardless. Every single woman had a cut. Every single woman was given the jab in the thigh. Every woman was given a managed labour, whether they wanted it or not. It was just all done and kind of taken out of your hands. And so we're in a better position now that we can have a say now. We can have a say. So again, have that conversation that, unless it's absolutely important, unless it's absolutely essential, natural third stage placenta delivery. And then vitamin K, again, we had this conversation. So this is used to assist the clotting process. And it is designed to stop bleeds on the brain, which we think there is a theory that it was caused by premature cord clamping and not delivering all of the clotting blood that is in the placenta prior to delivery. And this is something that a midwife spent years fighting for. So there is a theory, and again, you'll need to do your research on this and have a look at it, but there is a theory that actually if you have a optimum cord clamping, which is waiting for the placenta to drain all of that nice juicy post-birth blood to your baby, delivering them everything that they need, if that has taken place, then there shouldn't be a need for a vitamin K injection. But you'll need to do your research and have that conversation, because they're still giving these injections because it's just something that was always done. So you'll have to, because I've read some other research that said, no, it doesn't make any difference. But if it didn't make any difference, they wouldn't have gone through all this trouble of having this kind of like delayed, they call it delayed cord clamping, but it's optimum cord clamping. There would be no point having that. So I don't really see the rationale. But again, it's up to you to do your research, have those conversations. And then feeding. So while breastfeeding is considered the norm, it's not always physiologically possible. So if you've had any previous surgery on your breasts, like enlargements, augmentations, if you've had breast cancer, my friend had a reduction, she's a breast reduction, so she couldn't breastfeed. So there are reasons why, despite the will to do it, they might not be able to. So again, stay on your plan if you'll be bottle feeding. If you're planning on breastfeeding, you'll be given lots of help and support with that. And I've written that at the time when, that was the case in Samuel Johnson, where you could stay all week and they'd help you with feeding and bathing. And you might only be in there for 2 hours. They might kick you out after 2 hours now, so I don't know. But just to get health visitor visits. Yeah, so they come out, because they used to come out like every day for 10 days.
Yeah, come out once, my midwife said. And then as much as you need them, leave them.
Okay. And again, this is something that was run by Samuel Johnson, so I don't know if it's still the case now, but there used to be these breastfeeding clinics, and they're still running.
They do at Charnwood.
Yes, yeah, Lichfield, brilliant.
That's where I went from the door.
Yeah.
They were good there.
So they used to run them at the Guildhall, but I think they got taken to Charnwood. And then if they do them in Burton, you'll have to check, or wherever you are, if it's Sutton or Derby, check if you've got any breastfeeding support groups, because some of them, particularly the ones that are run by midwives, they'll do an antenatal one. So because actually you kind of need to know before, because you need to kind of know what you're doing prior to that baby coming out, because that's one of the first things you'll have to do. So that antenatal, they used to do special, once a month they do a whole clinic on antenatal.
I did one there, the first one, yeah. Remember doing that, yeah. It was like a couple of hours, I think.
Yeah, it's quite in depth, because as I said, that's when you need it. It's no good going.
Session on our NCT on breastfeeding, it was like 4 hours.
Yeah, but not everyone does NCT,
No.
so
I'm not sure they do the NHS one anymore.
Right. Yeah, I would check, because the NHS don't do them, but there may be like a positive birth group. I know there's one in Derby. I think it's at Mickletover. Positive birth groups. They will do them from time to time, and I'm trying to think who else might do them. Children's centres might. Well, at Charnwood, obviously they do it at Charnwood. So I don't know what their midwifery care is like at the big children's centre at Waterloo Street in Burton. I know they offer quite a few services there, so you might want to have a look and see. But it's probably worth, if you're planning on breastfeeding, just getting some antenatal breastfeeding classes in. And theoretically, there is a lot of help out there if you're having trouble postnatally. In practice, it's a bit hit and miss, but theoretically, the support should be there for you postnatally if you need it. So, as a bear in mind that any intervention will be, or should be, fully discussed with you as the need arises. Nothing will be done without your consent. Even if it's a very rushed, is this okay? Consent. Everything should be done with your consent. So if there's, I say that because I know a lot of women worry about things being done to them, like, I don't want this to happen. And it shouldn't happen unless there's an absolute, life or death situation, and then obviously you will make the right decision. But nothing should happen without your consent. So bear that in mind.
Is it worth mentioning it when you get a that you want to be consented for everything, or is that something they should actually do?
It won't hurt to reiterate that, but it's kind of a legality now, because you can sue the pants off if anything happens to you in hospital and you haven't given your consent. They can be sued. So yeah, they should always offer consent, but there's no harm in just reiterating when you go in that you want to be informed, and they need it. It's called informed consent. It's not just consent, it's informed. So they have to spend some time with you saying, this is what we need to do, this is why we need to do it, can we have your consent? Even if it's like 5 seconds of conversation. So yeah, one thing I would mention is this is something the midwives used to say to me, that if somebody walked in labour with a birthing ball, they knew straight away that they had somebody coming in who knew what they were doing, and they kind of, not so they treated them differently, but they knew that you wouldn't be high maintenance in a way unless something obviously cascaded, but it kind of like was a bit of a badge. You walk in with your birthing ball and it says, I've done a little bit of prep, kind of know what I'm doing, and so that kind of sets a different scenario. So it's quite a useful thing. We've done a session on birthing balls a while ago. We might do another one at some point, because I think a few of you probably haven't done it. So we will do those from time to time. Is there anything else? Any other questions about birthing plans that you want to ask while it's sort of fresh in your mind? Was that fairly similar to the one we did with the hypnobirthing?
Yeah.
Same sort of questions.
More like hushed voices, who you want to communicate with. So is it with me or is it with my partner? And then it's like every situation. So what's your ideal situation? What happens if you don't get that and you have to have a cesarean? We have to go on to a labour ward, and it's just like what you want in each situation. That was quite good, just so that if you did have to have an emergency C-section, there's some notes, and at least you feel a bit more prepared for it. So it wasn't just one direct plan.
I'll add them onto mine then. Yeah, that's quite useful, isn't it? Like a bigger scenario. So did you have like those diagrams where they go like, if yes, here, if no?
Yeah, it kind of does like, what's your ideal one? And then they kind of included all that, and then it's like, if I don't get my ideal one, and I have to so mine was in a midwifery led unit, and then I had to be transferred into a labour ward. What would I want the labour ward to look like? And then if I had to have a C-section, what would the C-section then look like?
Okay.
So what options do you have a C-section? What options do you have a C-section?
If it's like an emergency C-section,
Yeah.
you can have the dim lighting by your head, so the baby's not blinded when they come to you. You can ask for the monitors on your back so that you can have skin to skin. You can ask for the drape to be taken when they pull the baby out, so then it comes direct to you. There's lots of options, and you can have your own music. You don't have to have everyone in the theatre, you can just have the minimum possible people.
Thank you.
Yeah, which kind of makes sense, doesn't it? Because the least sort of aggressive the C-section can be.
Yeah, you can ask
for the
like
baby.
a natural, gentle cesarean if that's possible.
Yeah, I mean, you can't. The surgeon can't have a dimmed light.
No, but you don't have to have a light on your face.
Yeah. And they're quite used to working with music anyway, aren't they? A lot of surgeons have music on. Okay, so are there any other questions coming from that? Marvellous. Right.